Good morning, good afternoon, good evening to each and every one of you, to our dear HCP virtual classroom participants. We have with us today Dr. Imoro Braimah and Dr. Kwesi Arthur from University of Ghana Medical School. They are phenomenal. We are just so thrilled to have them to teach us Retina session number 3.
Thank you very much, Dr. Nariani, for inviting me to talk. And thank you, Dr. Braimah, also for the invitation. So in the attainment of knowledge, there is a path we have to go through. We all want to get the knowledge, but sometimes the exercise in getting the knowledge is more important. And the way we achieve the knowledge is extremely important. And the reason why I bring this up is because I've been asked to cover a multitude of retinal conditions in 40 minutes. And it's going to be almost impossible for me to do justice to any one of these topics, let alone to a host of diverse topics in the time we have. I might have to skip over some of the things in the chapter. I might briefly mention some things, and I might not go in too much detail in other things. Throughout, I'm trying to use some cases and try to bring up some systems and ways of thinking and try to educate in that way rather than formally spoon feed and teach everything. So our first case is this 42-year-old banker who presented to our clinic. Does anybody want to describe the photograph to us? So I got right eye and I think I had pigments. Okay, so we have a right fundus photograph. We have some pigmentary changes, and these pigmentary changes are sort of mid-peripheral. Does anybody want to give us an idea of the diagnosis? Yes, so Dr.
Retinitis pigmentosa.
Exactly, retinitis pigmentosa. So that is a traditional diagnosis that we would give for this. I've seen somebody's talking about waxy pallor of the optic disc, and I've seen someone talking about the vascular changes, arteriolar attenuation. In this particular fundus photo, the optic disc doesn't have that classic waxy pallor appearance. However, we have all these hyperpigmented changes, and we have some hypopigmented changes next to it as well. And this is what we would classically call retinitis pigmentosa. When somebody comes to you in the clinic with this, that's just the first step. The first step is that we know there is a retinopathy, and we know there's a pigmentary retinopathy. However, when we start to think about different conditions that cause retinopathy and different conditions that cause pigmentary changes, we have to think more in terms of classification of these conditions. And one of the ways to think about it is to think about whether it is the photoreceptors that are affected, it is the RPE that is affected, or it is the choroid that is affected. If we think it's the photoreceptors that are affected, then we call it a rod or a cone, or a rod cone dystrophy, or a cone rod dystrophy. In this particular photo here, you can see more of that waxy pallor. You can see that the vessels are attenuated, particularly the arteries. And you can see that the hypopigmentary area has become larger. Okay. In this other photograph here, you do not have as much pigment, but you have a lot of changes at the macula and around the disc. You have all this hypopigmentation, and this is what we'll call a macular dystrophy. So we're moving away from saying retinitis pigmentosa, and we're moving more towards using terms like inherited retinal dystrophy and trying to classify the inherited retinal disease more appropriately. Traditionally, there have been a couple of ways of doing it. One of the ways is whether the condition is progressive or stationary. Stationary means that the damage doesn't progress over time, and progressive meaning obviously that it progresses over time. It depends on whether the rods are predominantly affected or the cones are predominantly affected. There are multiple inheritance patterns, okay? And we'll come into that in a little bit more. The chapter that we're talking about is mainly considering syndromic causes of retinitis pigmentosa. And these can be further subdivided into what we call ciliopathies, okay, such as Usher syndrome, which we all know causes retinitis pigmentosa and hearing loss. Bardet-Biedl syndrome, which you get classically polydactyly, you get some change in intellect, and you can get a coloboma in association. Joubert and Senior-Loken and Alstrom, which have associated renal impairments as well. We can also have mitochondrial disorders, and the one that we normally talk about is CPEO, or chronic progressive external ophthalmoplegia, but Kearns-Sayre syndrome is that aspect of it that has a pigmentary retinopathy. Paroxysmal disorders, lysosomal storage disorders like mucopolysaccharidosis, and all the various types. When we come to the choroid as well, we can have issues there: choroideremia, gyrate atrophy, and late onset retinal dystrophies. With regards to the stationary retinal degenerations, we tend to have them where they affect just one photoreceptor or one class of cone photoreceptors. Okay, they tend to have particular ERG patterns, and these can help us in the diagnosis of them. We have these two fundus photos here, kindly given to me by Dr. Braimah. There are two photos of the same person and the same eye. Does anybody have an idea what's going on here? Thank you, Dr. Ting. So Dr. Ting has put in the Uguchi syndrome, okay? So this is a problem with the photoreceptor transduction, where basically in dark adaptation, we have the normal retinal picture, and then in light, we have this phenomenon, which is called Mizu's phenomenon. The reason why this is interesting is because it helps us to understand what happens in the pattern of these inherited retinal dystrophies. In a normal gene, there is a normal protein which is expressed. If we have a mutated gene, then we can have one of maybe 4 problems. First problem is that there is no protein expressed. Second problem is there is inadequate amount of protein expressed. Third problem is there is too much of the protein expressed. And fourth problem is that there is an abnormal expression of the protein. And any of these can go on to give us a particular phenotype. Now, what we are becoming more and more aware of is that these phenotypes and their genetic predispositions are actually very interrelated. And a lot of the genes that cause one phenotype might be affected in another phenotype because it depends on how the protein is expressed in the microenvironment. Okay. So it's very important to realize now that some of these phenotypes we are talking about overlap with each other, and that the specific genetic entities might be all from the same gene mutation. The other thing to think about as well is what happens to the retina when we have these genetic mutations. If there is a problem with a protein that affects transduction, like we have in Uguchi syndrome, then we're obviously not going to have signal passing as appropriately as it should. If we have a problem where there is enhanced number of S cones, then we're going to have more S cones than the other type of cones. If we have a problem where a protein that is responsible for the rod structure is affected, then the rods will be damaged. Now, the problem is anything that happens at the photoreceptor level affects the microenvironment, and the RPE subsequently becomes affected. Anything that happens at the RPE level can cause a change in the microenvironment, and then the photoreceptors get affected. The same can be said for bipolar cells, ganglion cells, etc. And the bottom line is that with all these changes and with all this loss of tissue, we get atrophy, we get a thinner retina, and retinal function changes, which causes the problems that we have. Moving on to the next chapter, which talks about drugs and drug toxicity. There are a lot of drugs that can cause toxic effects in the retina. And this slide kind of summarizes all of them. I will not dwell on this slide. All I will say is that there are lots of drugs. We have to understand the damage they cause. We have to understand what we look for, and we have to remember some of them. The one that we'll dwell into is chloroquine, because that is quite topical. We all need to be aware of the antiretroviral therapies. We need to be aware of methanol toxicity, and we need to also be aware of things like tamoxifen retinopathy. With regards to hydroxychloroquine, traditionally, if it's obvious, you would get a bullseye maculopathy, and this bullseye maculopathy is quite easy to see. When you see a bullseye maculopathy, you shouldn't just jump straight into a diagnosis of chloroquine or hydroxychloroquine retinopathy, because there are other causes, other macular dystrophies that can cause a bullseye maculopathy. One of the things to look for is this suturization of the ellipsoid zone in the OCT. And over time, you get marked atrophy of the foveal and parafoveal area. The incidence of hydroxychloroquine retinopathy is relatively low. And you have to pass a certain threshold with regards to the dose of hydroxychloroquine or chloroquine. These days, it's very rare to see people being treated with chloroquine itself, and it's more likely to see people treated with hydroxychloroquine. The threshold daily dose is greater than 6.5 milligrams per kilogram. And with regards to chloroquine, it's less at 3 milligrams. Or if they've had a cumulative dose of greater than 1,000 grams for hydroxychloroquine and 460 for chloroquine. We also have to remember that if the person has any renal failure, any hepatitis or cirrhosis, or if they have any pre-existing maculopathy, then they are more at risk of this problem. We get asked a lot by our colleague physicians to assess people. And when it's very early, it can be difficult to pick up. One of the things that helps is looking for a paracentral scotoma. And the best way to use that is to use a 10-2 and not a 24-2, as you get a better appreciation of the paracentral areas. I'll move on to the next chapter, and I'll spend a bit more time here because these are retinal disorders that we come across more frequently. The vitreomacular interface, as we all know, is a complex interplay between the vitreous, particularly the posterior vitreous cortex, and the ILM. It is now well understood that there are laminin and fibronectin molecules connected into the collagen fibrils of the vitreous interface. And as such, we do not see them necessarily as two separate structures, but as two fluid structures with a transition zone. So there's a transition in the middle where they kind of meld into each other. There's some new terminology and it can be confusing. However, it's important that we all understand the new terminology because we want to make sure that when I say VMT in Ghana, it means the same thing in Ethiopia and it means the same thing in Nepal. I want so that when I tell you that we've done macular hole surgery for a moderate macular hole with vitreomacular traction, we all know what we are talking about. The basics of the vitreomacular interface is that there has to be a PVD with everyone with age. And unfortunately, where we have an anomalous PVD, we're going to have the opportunity to have traction for an ERM to form or to have a macular hole. PVD grading, there are a couple of different methods. This is the one I use, but this has kind of been surpassed with the advent of OCTs. Now, what I would say from a clinical perspective is until the posterior vitreous cortex is completely separated from the optic disc, it is not a complete PVD. We have to be able to see a vice ring to say that we have a complete PVD from a clinical standpoint. Now, a PVD can be an interesting thing. This is an OCT of my own eye. And where we look at it, we see that my hyaloid or my posterior vitreous cortex is there. It's attached along the fovea, and then it starts to separate against there. What we would hope for is that over time, this separation will be complete, and we'll have a full separation of the posterior hyaloid from the ILM. Unfortunately, that doesn't always happen. Now, if it's just like how you had it in my eye, then we have what we call vitreomacular adhesion. Now, wherever we have vitreomacular adhesion, it can be focal or broad, and it can be isolated in that it happens on its own or is concurrent to another disease. We can also have VMT and full macular thickness, which I'll come on to. So here we have two photographs. I'd like people to tell me which one is focal VMA and which one is broad.
So number 2 is broad, the one on the right.
Great, thank you.
Yeah.
So we said that focal VMA is less than 1,500 microns and broad VMA is greater than 1,500 microns. So it's relatively simple and easy to remember. Now with vitreomacular traction, using the International Vitreomacular Traction Study Group classification, we need 3 things. And these 3 things must be seen on the OCT scan, okay? Now, we have to have evidence of some perifoveal vitreous cortex detachment from the retinal surface. So there must be an area where it is lifted off. We need to see that there is still an attachment of the vitreous cortex within a 3 millimeter radius of the fovea. And this attachment should cause a distortion of the foveal architecture. So basically, there should be a change or an elevation of the foveal tissue above the RPE. But remember, there should not be a full thickness interruption of all the retinal layers. That is the key step in this. So we have 2 things with VMT here. The first one, we have focal traction. It's changing the morphology of the fovea. and there is no other thing associated with it. In this one, I'm telling you here that there's a previous BRVO. You might just see some blood here. We have a broad attachment, but it's still causing traction. Okay, so with these, we will have a focal and isolated, and a broad and concurrent. I see a question about a way to identify early VMT from slit lamp examination. It is extremely, extremely difficult. In the old days, what we used to call an impended macular hole, a lot of the time when you go back and you OCT these clients, you realize that there was some VMT. Sometimes it's the history that gives it away and makes you look at the fovea closely. If you do a Watsky-Allen, it will not be positive because there is no break through the ellipsoid zone. So the Watsky-Allen will be normal. Sometimes you see a little dimple or you see a change in the reflex of the fovea, and that might be the clue that you get. One of the stories I've told some of our residents is prior to OCTs being very available, we had a patient who kept coming and complaining of some mild visual distortion, and it was very difficult. We couldn't find anything wrong with her. And when we got the OCT and we scanned her, we saw that there was vitreomacular traction and explained her symptoms. So it is very difficult on slit lamp to make the diagnosis. So here we have someone with diabetes who has a subhyaloid hemorrhage, okay, and they have some vitreomacular traction, okay. So this would be a focal traction with a concurrent subhyaloid hemorrhage. Now, as you're having this separation of the posterior hyaloid from the ILM, there can sometimes be access for fibrocellular changes on the surface of the retina, either RPE cells, molar foot plates, molar cells, glial cells, whatever. When they get there and they start to proliferate, you get this fibrocellular membrane forming just on top of the ILM. And this fibrocellular membrane has been called multiple things. It's been called an epiretinal membrane. It's been called an epimacular membrane. It's been called cellophane maculopathy, and it's been called macular pucker. Patients typically present with minimal symptoms, mild distortion, unless it gets really bad, and then they complain quite bitterly about distortion. An epiretinal membrane can be secondary to things like previous retinal detachment surgery, previous laser, previous cryotherapy, previous retinal vein or retinal artery occlusions. So every time you see an epiretinal membrane, you should be cautious that there's no other cause for it. As the epiretinal membrane begins to contract, it begins to change the architecture of the underlying retina, and it becomes quite difficult for these people to see. The surgery is relatively successful. However, you need to give them time for visual improvements. Another question we get asked a lot is something like this, where you have an epiretinal membrane in conjunction with cystoid macular edema. Which caused which? Was it the epiretinal membrane that caused a cyst, or the cyst is what has made it look like the epiretinal membrane is significant? It can be difficult sometimes, and sometimes it can be relatively straightforward. What I would say is where the foveal architecture is generally normal, it is unlikely to be the epiretinal membrane causing the problem, but not always. The other thing I would say is that sometimes what we will do is we'll treat the CMO first and give ourselves a deadline. We'll say 2 or 3 months. If the CMO does not improve, then we'll remove the epiretinal membrane. Lamellar macular holes are the other thing that can happen at the vitreomacular interface. Now, what we have with a lamellar macular hole is we have a cystic component that has broken down. And once it breaks down, you get a split in the retina. It is not a full thickness break, and almost all the time, the ellipsoid zone is intact. So you'll find that the external retina is fine. The ISOS junction is fine. So you have an intact photoreceptor layer, okay? An intact photoreceptor layer means that the vision is generally good. So those of you who've seen people with lamellar macular holes, you remember that the vision is generally good. These patients might have some symptoms, they might not. It depends on whether they had the cysts for quite a long time before they broke down or not. But the one thing I'll say about these cases is that they're not very satisfying to do surgically because the outcomes are not always good. They don't tend to have as much improvement as you'd have thought they would have. Okay, so with regards to best time for surgery for ERM, I think Dr. Braimah is going to talk about surgery, but I'll just cover that quickly. With regards to me, I have, there's nothing written in the books. It's basically based on patient symptoms, duration of symptoms, etc. But my internal cutoff is 618 or marked distortion. Okay. The other question we have is, how is it that Wadsky-Allen test is negative, but the patient has macular hole? I saw a patient today with macular hole today, full thickness, but the test was negative. So it depends on a couple of things. One, how was the test done? Was the beam extreme? What was the thickness of the beam? Because if obviously they see parts of the beam, they might say it was normal. Sometimes patients don't fully understand. I'm presuming it was a full thickness macular hole because once again, if it was a lamellar macular hole, they might still have vision. So there are a couple of potential things that would have caused that. The next condition is a pseudohole. Now, what happens in a pseudohole is you have an epiretinal membrane that sort of heaps around the fovea, and it causes like a stretching effect around the fovea. And you get this sort of verticalization of the fovea. The verticalization of the fovea is quite easily seen. And it's not a real hole because once again, you see all the layers, the ellipsoid layer, everything intact. Patients can be quite worried about this, and their symptoms will be similar to an ERM symptoms. Generally, I would operate on these. I would give them a lot of counseling prior just to make sure that expectations are met. In the old days, we used the gas staging, which I've kind of alluded to, but with the new IVTS classification, it kind of merges onto the gas stage. So no macular hole is a vitreomacular adhesion. An impending macular hole is vitreomacular traction. And a small hole is still the same. It's a small hole. But the only thing is now we have to say whether there is concurrent there is associated vitreomacular traction or not. And then we have a medium hole and we have a large hole. Okay. So now basically with macular hole, all that matters is whether it's small or medium or large, and whether there is vitreomacular traction in association or not. In order to classify the holes, we have to know the measurements. So a small hole is less than 250 microns. A medium hole is between 250 and 400 microns. And a large hole is greater than 400 microns. Once again, we decide whether there is VMT or not. So we have a few examples here. We have a moderate sized hole with vitreomacular traction. We have a large hole with no vitreomacular traction. And here we have a small hole. Okay, so it's very easy to use the new staging system. So just to recap, we have a vitreomacular adhesion. It's broad because it's greater than 1,500. We have a focal vitreomacular traction. We have vitreomacular traction with a small macular hole. And then we have a normal foveal anatomy. So those are just to recap. This was a patient who was referred to us, who I think is interesting because one of the things we sometimes forget about is causes of a macular hole. How would anybody deal with this if it came to them in their eye casualty or emergency or primary care clinic? We have some commotio. You can see the change in color, and then we have some blood. An OCT may help, but remember that because of the blood, it'll be difficult to see the OCT. And we see this fluid level here. Every time we see this, it basically tells you that the blood is subhyaloid, okay? And you have some slightly older altered blood sinking to the bottom. So we gave this patient some time. We saw them, and this is what had happened, okay? They had a large macular hole, okay? We operated on this patient, and they did well.
How can you tell that this is subhyaloid for our first-year residents that are on the call? What are some clues of what layer of the retina you're looking at?
Okay, great. So it's a good question. One of the things I tell everybody all the time is look at the blood vessel and see what is happening to the blood vessel. If the blood vessel is obscured by the blood, then the blood is in front of the retina, okay? If the blood vessel goes over the blood, then the blood is under the retina. So that's one of the clues. Every time you see a fluid level like this, it's most likely going to be a subhyaloid hemorrhage as well. So this is a young lady who has midfacial hypoplasia. I've said high myopia here, but as I look at her glasses, I'm not sure she's that high myopic. She had some arthritis. She had some mild sensorineural hearing loss, and she had a cleft palate from a thing called a Pierre-Robin sequence. And this can be quite a difficult diagnosis to make if you're not looking for it. And that's one of the challenges with some of these rare things. Although they are rare, from time to time we will see them, so we have to be aware of them. This is another patient, old patient of mine, and she had an almost optically empty vitreous cavity. She had very syneretic-like vitreous. She didn't have any problems with cleft abnormalities. She didn't have any hearing problems, and she didn't have any arthropathies or arthritis, though they normally present in the third decade with that. Stickler syndrome was predominantly thought to be just autosomal dominant. It's a collagenopathy, so it's related to a collagen vascular disorder. There are two main types, and in the two types, we get a different type of vitreous that we see. Now, it's quite hard to identify this vitreous, but normally when you look into the vitreous cavity with your slit lamp, what you're doing is, without using the lens, you're focusing on the posterior capsule. Without using a non-contact lens, you're focusing on the posterior capsule of the lens and pushing your slit lamp slightly forward and then sweeping across with your light, okay? So that you can try and look into the void. And normally you would get an appearance that there is some strands of things inside there. But with somebody with stickless, you might have one of a few things. You might have a slight ragged membranous change. You might have one or two little beaded changes. You might have a fibrillar appearance that's quite hard to see. It wouldn't be like a normal vitreous. And if you're struggling to see it, technically you should be able to use an ultrasound scan to do this, but it's extremely hard to do. When we examine their fundus, they get a pterygoid fundus-like appearance. And once we've got a pterygoid fundus-like appearance, we have to be cautious whether it's a myopic fundus or it's something else. With respect to their peripheral retinal appearances, we have this thing called radial lattice degeneration. So normally lattice is concentric, but when you get radial lattice degeneration, you should be cautious about Stickler syndrome. And it's normally perivascular, so it follows the arcade as well. The reason we are concerned about Stickler syndrome from a retina perspective is there's a high risk of giant retinal tears. And in this patient, you can see that they've had a previous buccal surgery. Okay. This is one of my patients where I was convinced she had Stickler syndrome, and I was trying to find out if the vitreous cavity was optically empty. And like I said, it's not the most easy thing to do. Normally, we say Stickler syndrome is autosomal dominant, but just to be aware, recently there's been an autosomal recessive form of Stickler syndrome found, which is collagen 9A1. Okay, so the main thing to look for in the diagnosis is to look into the vitreous cavity to see whether the vitreous cavity is present or not. Normally, what will highlight you to do that is the high myopia, it's the midfacial hypoplasia. Okay, if they have any other issues like hearing loss or arthritis, those will also be clues. And then look, when you examine them, look around the equator and look anteriorly for this radial lattice degeneration. Wagner syndrome is a variant of Stickler syndrome. Once again, collagen 2A1. And this time they don't have any systemic features, okay? All the features are ocular. Thankfully, they don't have as much tractional retinal detachments as you have in the other one, in Stickler syndrome, though they can have cataract and they might have anterior segment dysgenesis.
There's a question on the chat, how to diagnose clinically regarding this, and previously, do stage 1 macular hole and pseudo hole synonymous?
No, stage 1 macular hole and pseudo hole are not synonymous. They're totally different things. So if you remember, we talked about an epiretinal membrane causing verticalization and invagination, okay? And it is not full thickness. Whereas in a macular hole, there is full thickness break, okay? So they're not the same. With regards to clinical diagnosis of Sticklers, as I said, the history, high myopia, sensorineural hearing loss or arthritis, looking in the vitreous cavity, like I explained with the slit lamp, to see whether there is vitreous present or not, looking at the retina, looking at radial, what's it called, radial lattice. And then if you're lucky and you work somewhere where they have genetic testing, you can always send for genetic testing. But for most of us, that is not an option. One of the conditions I'm interested in as well is fever, familial exudative vitreoretinopathy. And basically, this is a developmental anomaly of retinal vasculature. Initial descriptions gave it amazing resemblance to ROP. So if you looked at this and you saw this line here, you think that was a ridge, but it's different, okay? And once again, it's got a multitude of genetic background, but basically what we have is we have an exudative vitreoretinopathy, and the key is that they are not premature, okay? They are full-term babies or children. There might be a family history, there may not be a family history. And sometimes if you look in the parents' eyes, you might see some changes, because even in the same family and in the same person, there could be varied expressivity. Ultrasound scans can be useful, and EUAs are almost important because it's very hard to see the peripheral retina without the help of an EUA. This is one of our patients where you can see the ridge here. You can see some bleeding beyond it, and you get almost this sort of avascular retina beyond this area. And if you see this eye looks worse than the other eye, in this patient, we did quite a good amount of laser, okay? And we're able to control them that way. It's not always that way. So the first picture I showed, this is the other eye, a non-seeing eye. And in this particular eye, we did a lot of work. We did some laser, we gave some injections, and we still had this sort of shifting fluid at the macula. Now, using the ultrasound scan to clarify diagnosis in children is important, because sometimes it can help you to distinguish whether it is a fold, whether it is a stalk, and whether it's a gliotic membrane, okay? Sometimes it might not help you. Sometimes it can help you to decide whether it is tunica vasculenta or something else as well. So in this patient, we did a lot of laser. So this is pre and this is post laser. There's still quite a lot of exudation, and then we gave some injections to help. The challenge is that we don't really know how VEGF is helping. We don't know how to dose them. We don't know what the length of treatment is. We don't know what the endpoint of treatment is. And the complications in pediatric population are still yet to be fully elucidated. But this is how they looked afterwards. And at this point, you just have precipitation of the exudates. There wasn't as much fluid as before, as you can see on the ultrasound scan. So fever management is extremely difficult. I think sometimes we have to call it quits early on to spare these children unsuccessful procedures. We need to identify those who benefit from early and aggressive treatments, and we need to offer it quickly.
Question in the group is laser or anti-VEGF better for fever? And how do we differentiate with ROP, especially in preterm babies?
Yeah, so laser or anti-VEGF, I prefer laser, okay? And no specific indication other than that is how I was taught. We then started using some anti-VEGF as well. The jury is out as to how good it is. It's extremely difficult to treat, so most of the time we end up using both laser and anti-VEGF. With regards to differentiating with ROP, essentially if it is preterm, it is ROP, okay? And if it is term, it is fever. It is very rare to have, a term, well, term ROP doesn't exist, but it's very rare to have a preterm fever child, okay? It's extremely rare. I'm not saying it doesn't happen, but basically that is the main thing that helps us to differentiate. So we're meant to talk about vitreous hemorrhage as well in this chapter. And it's just such a large topic that I honestly don't know where to start or where to finish with regards to this. What I would say is that I would concentrate on vitreous hemorrhage of unidentified cause. So somebody walks into your clinic, they are not diabetic, they don't have sickle cell, they don't have any other vascular retinopathy that you know of, and they have a vitreous hemorrhage. What do you do? I think that given how modern vitrectomy is, and given the risk that you might have a retinal tear with a bridging vessel, nowadays, most people will be inclined to act sooner than later. Obviously, when they present, you do all your investigations, you do your ultrasound scan, you ensure that there is the retina is attached, and you have a frank discussion with the patients. Okay, but I know that if this was my eye and I had no underlying cause, I would be more willing to have an early vitrectomy to prevent problems rather than wait on it. Now, it's very controversial, especially where patients have to pay, especially where there isn't access to vitrectomy surgery, etc. But it's one of the things that I want us to all start thinking about nowadays. With regards to vitreous hemorrhage from diabetes, it is a terrible thing. And I would encourage everyone to laser aggressively, whatever the rest of the retina you can see to laser, refer to a vitreoretinal surgeon as quickly as possible, and treat them aggressively early to prevent further visual loss. Okay, move on. So Norman Byers is a US ophthalmologist who's done a lot of work, and basically his work entailed following up a lot of eyes over a long time. And he has a couple of case series. And in one of them, he followed up round holes, okay? And he followed them up for 10 years, okay, for 60% of them. And one of the things that he realized was that if you had an asymptomatic operculated hole, it was highly unlikely that you would go on to develop a retinal detachment, okay? So that is something that we all need to carry in our back pocket. With regards to things that can cause a retinal detachment or things that are risks for retinal detachment, there are quite a lot of them. Okay, lattice degeneration, which is present in 8% of the population and commoner in myopes. And like I said, normally lattice degeneration is concentric and not radial like you get in stickless. Okay, it represents thickened vessels which are exposed due to atrophic retina. Now, because you have this sort of syneretic vitreous over the lattice, it can cause breaks or holes. Now, if the hole is full thickness and is operculated, or if there's just a hole, then you know that there's no traction on the retina. And the thing that causes the problem is traction. So if you look at this U tear, this leaf of the retina is under traction. The vitreous is sort of pulling it. And every time it pulls it, it allows more fluid to go through the break. When you have a hole, you don't have that sort of traction, okay? So RD is normally due to tears and not normally due to holes. You can have retinal hole RDs for sure. In retinal hole RDs, they're typically younger patients and they tend to be myopes, okay? Normally, the fellow eye will also show holes in a mirror distribution of what the eye of interest is showing. Snail track degeneration, you get wider areas than lattice, and U-tears are extremely rare with this. Retinoschisis is something we talk about a lot. It's present in about 5% of the population. It's most often bilateral, okay? The only time a retinoschisis becomes a problem is if you have a break in both the outer leaf and the inner leaf. And this break basically means that fluid can traverse all the way to the subretinal space. They can be extremely difficult to manage if they get a retinoschisis retinal detachment. White without pressure is very common here. Initially, there was some thinking that there might be tears developing along the posterior border. I think that this thinking is changing because it's just so common now. We see it so frequently that I think that we will realize if there was a specific problem. Myopia is something we should be aware of. In most countries, it's 10% of the general population. I know that in Asia, it's a bit higher, but it's 40% of the RD population. And the higher the level of myopia you are, the relative risk is slightly higher as well. So when would I consider prophylaxis? I'll consider prophylaxis if there is a tear. I'll consider prophylaxis if it's symptomatic. I'll consider prophylaxis if there's pigment in the vitreous cavity. I'll consider prophylaxis if the fellow eye also has an RD, or if there's been previous cataract surgery, or if they are myopic. If they have other issues like Marfan syndrome, stickless, or Ehlers-Danlos, I also consider prophylaxis. If they have a familial predisposition, I'll have a discussion with them about what to do. It's a very contentious topic to do prophylactic treatment in someone's eye because they are relative at a retinal detachment. Now, if they were asymptomatic and there is no fellow eye RD, I think the main thing is to work out if it's a tear or a hole. If it's an opaculated hole, normally I wouldn't bother because once, like I said, it's the vitreoretinal traction on the tear that's the most important thing. Patients with fellow eye RDs, I'm a bit more cautious about. Okay, so I would treat promptly if they had a U tear. However, if they were symptomatic without traction, I would treat. If they were asymptomatic, I would really consider treating just because of what has happened to the fellow eye. So basically, the risk metric changes based on the patient's symptoms and the patient's clinical findings. A lot of my colleagues will advocate treatment of all breaks in eyes with fellow RD. However, you have to remember that laser isn't without its risks, okay? And that also you can have a new break even after doing laser. So you have to be extremely careful about how you articulate all of these things. With regards to the type of prophylaxis modality, slit lamp delivery is the easiest. It is relatively less traumatic, and it's good when there's multiple breaks, etc. You can also do indirect slit lamp delivery. Indirect delivery of 532 or argon laser. You can also do cryotherapy. Sometimes we forget about cryotherapy and we don't have it in our armamentarium, but it's something that can be useful and helpful, especially for small holes that are slightly difficult to find with a laser. As I said, there can be complications. Sometimes we do not prevent an RD. Sometimes a new break occurs elsewhere or at the edge of our laser. If we laser aggressively, then we can have tissue damage. The chances of having necrotic retina are high, particularly with a lot of cryotherapy. We talked about epiretinal membranes, and obviously that's something to think about with regards to heavy laser and heavy use of cryotherapy. Blood retinal barrier breakdown, especially, also releases RPE cells, platelet-derived growth factor, and other things, which can also cause some inflammation and further cellular proliferation. Okay, so if they're large lesions, I'll prefer to laser rather than do cryotherapy. So with regards to retinal detachment, there are a few things that we have to work out. Is it regmatogenous, in the meaning that is there a break? Okay, and we've gone through breaks earlier on when we talked about the U tears. The incidence is, relatively modest, 1 in 10,000 per year. We normally have a convex shaped retinal detachment. It'll have a corrugated sort of appearance, okay? And like I said, there will be a break. And the break might be hard to find or it might be easy to find. The next thing we have to decide is whether a retinal detachment is an emergency or not. And for that, we need to work out whether the macula is on or off. And this is one of those things that some people find confusing. The macula is basically from the fovea to the optic disc, the circle that you draw, everything in there is the macula. So if the fluid is just inside the arcades, it is in the macula and the macula is off. For those of you who have access to OCT where you are not sure, you can check it. But generally, if the person's vision is down or reduced, it is very likely that the macula is off. The other thing to work out is what are the other features? Is this a chronic retinal detachment with a demarcation line and intraretinal cyst or not? Something like this, it's been long-standing. You might not need to intervene as quickly as with a fresh macula on retinal detachment. The other thing then to work out is whether it's an exudative retinal detachment. So by exudative retinal detachments, what we mean is that there is no break, there is no communication between the subretinal space and the vitreous cavity. There is something happening that has changed the RPE pump mechanism and fluid is being recruited under the retina. Most of the time it's related to inflammation or some specific retinal disorders. The other thing we can have is a tractional retinal detachment, and we can also have a lot of proliferative vitreoretinopathy, which is scarring of the retina. Where we have a tractional retinal detachment, what has happened is that something inside the vitreous cavity has contracted and it is pulling the retina off. The traditional thing will be diabetic retinopathy causing a tractional retinal detachment. And in this diabetic, you've seen that they've already had some PRP laser along the side. There's some clinical features that we look for in a retinal detachment. I've talked about proliferative vitreoretinopathy, and what that is scarring, okay? So in some eyes, when RPE cells are liberated into the vitreous cavity, it causes marked scarring, and this makes it hard, and the prognosis is reduced with proliferative vitreoretinopathy. The size of the break, so if it is larger than 3 clock hours, it becomes a giant retinal tear. If the retina is disinserted from the ora serrata, then it becomes a retinal dialysis. So these are some of the features that we'll look for in a retinal detachment. If there's trauma associated or if there's blood around, once again, that's a poor prognostic feature, and we would like to intervene sooner rather than later. There are other types of retinal detachments, and I just put this picture here. If anybody can talk us through it, what they see and what they think the diagnosis is. Mohammed and Dr. Mulata, please unmute yourself and talk, okay? And tell us why you think that's the diagnosis.
Who has serious retinal detachments?
Okay, so we have a retinal detachment here. It's very subtle. You see this striae, okay, and you see these sort of concentric lines. Okay, there's fluid under the retina. And then if you look here closely here, you see the sort of pale yellowish change. There's an optic disc pit here, okay? So this is a special type of retinal detachment, and there are some other ones. And I just showed this picture because it's interesting more than anything. So just to recap, with regards to the break, we can have a U tear, we can have various J tears and etc., but they are all essentially like a U tear. We can have a round hole with an operculum, we can have a dialysis, and then we can have the giant retinal tear. And sometimes finding the break can be the extremely hard thing, and it's been described variously as finding a needle in a haystack. And here we have somebody called Dr. Linkoff, who came up with some rules, okay? And these are some of the rules that you have to look up just for your own sake to help you. The way to think about this is that wherever the break is, the fluid line, okay, is going to help you to identify it, okay? So if the break is at 6 o'clock, all right, the fluid will be equally distributed along both sides of the optic nerve. The fluid will be higher on the side of the break, okay? Now, if you have a bullous retinal detachment, okay, then you could have a sinus at the top, so a small break with a track of fluid going all the way around. When the break is on the superior aspect, okay, the fluid is going to be higher on that side, okay? And if it is at 12 o'clock, then it's going to be almost equal. All right, so these are Linkoff's rules. Okay, so this is a simple sort of thing I put together some time ago, just to help with trying to gauge what happens in a retinal detachment in a child. Okay, so first of all, you have to decide whether it's related to trauma or not. So we're looking at non-traumatic retinal detachments. You have to decide whether they have some sort of syndrome or not. If they don't have a syndrome, then you have to work out whether there is nystagmus, nyctalopia, reduced best corrected vision, and you're headed towards electrophysiology to help you with the diagnosis. Where you notice a problem with the lens, then you're headed towards a connective tissue disease. If there is some developmental delay, abnormal stature, etc., then you're headed this way. If not, then you have to look at the vitreous cavity to try and work out whether there is a collagenopathy like Stickler's. If they have a small head, then you're headed towards a macular dystrophy, a muscular dystrophy. And if there's no small head, you look at the retinal vasculature, decide whether they are premature or not, you're headed towards a fever. If they have retinal dysplasia, then you're headed towards Norris disease, and so on and so forth. So it's like a little aid memoir to help. Thank you. And let me take the questions. So a vitreous hemorrhage in a diabetic, it depends on quite a few things. As you're realizing in medicine, there's not one clear answer for everything. So I would consider whether I have done enough laser already or not. If I've done enough laser, I'm more likely to want to hold on. I'll consider whether the other eye is affected or not. If the other eye is affected or the other eye is blind, I'm more likely to move on and do something. I'll consider how debilitated the vitreous hemorrhage is. If the vitreous hemorrhage is extremely debilitating, then obviously I'll be moved to do something. I'll look at what their if I know the patients, what their pre-vitreous hemorrhage retinal photos look like. And basically, I would decide whether to intervene or not based on that. Okay. Now, there are a lot of other things, when you start to think about this. What does the patient understand about the risks and benefits? Was there any vision in that eye? So it's not straightforward. But what I'll say generally is that we are now moving away from waiting for the length of time that we used to wait. And we are more inclined to intervene early, okay? Because modern vitrectomy surgery has become so good. We really can get good results if we intervene earlier, okay? The next thing is, how long shall we wait in case of vitreous hemorrhage after trauma before any intervention? Okay, so I think Dr. Braimah will handle this because he's going to talk about trauma. So I'll leave that for him. How is the hemorrhage cleared from the vitreous? So normally what happens is that the blood gets disintegrated and it is cleared through the trabecular meshwork like fluid. Okay, and this can actually give rise to a thing called ghost cell glaucoma, where you get raised intraocular pressures because of the blockage of the trabecular meshwork. So when we put silicone oil in the eye and we take the silicone oil out, the aqueous humor from the front of the eye will go to the back of the eye and fill the cavity. Okay, and that is why this happens. Okay, yeah. So somebody's answered the scotoma question. So basically, just like Dr. Deso has said, what you have is basically the neural retinal tissue has split, and that is called severing of the nerve cells. Subclinical retinal detachment. Is that always mandatory to treat despite any location? So this is once again, there's not one answer that fulfills this criteria. When we say subclinical retinal detachment, what do we mean? Okay, so if you have a peripheral small amount of fluid with a demarcation line and it's been there for a long time, obviously I'm not interested. If you have fluid under the fovea with recent onset of symptoms, like just a small amount of fluid, I am very interested. So it all depends on progression, okay, and where it is. Okay, and Dr. Halo has answered that one as well. So I think those are all the questions.
We will hand it over to Dr. Braimah.
Thank you very much, Ashiana, and then also Kwesi for starting this session. I'll be giving you a summary of chapters 17, 18, 19. Hopefully, we may talk about one or two things in chapter 20, which Kwesi mentioned earlier on inherited retinal diseases. So the first chapter is on posterior segment manifestation of ocular trauma. And ocular trauma is an important cause of visual impairment, especially unilateral loss of vision worldwide. And as a clinician, your initial evaluation, you should decide whether you are dealing with an open or closed globe injury and whether there's intraocular foreign body present. Imaging is an important modality in our evaluation of the ocular trauma patient. And apart from helping us know the various damages to the eye structures, it can tell us whether there's a foreign body or not. So I'll start off with why will you not do MRI in someone with a metallic intraocular foreign body? Well, yeah, I've seen an answer that metal may dislodge. You know, MRI has a strong magnetic field and the magnet can move the metallic foreign body, especially ferromagnetic foreign bodies around, and cause further damage to the eye. And that is why the most preferred modality in such a situation is CT scan. Good. The other bit about penetrating injury is the risk of endophthalmitis. In severe ocular injury, vitrectomy techniques play a role in their management. So there are general principles of management of the ocular trauma patient. And first one is you should treat the person as a whole, not someone with just an eye injury. And systemic injuries take precedence over eye injury. And you should try to protect the globe from further injury. Now, the Birmingham eye trauma terminology has classification for ocular trauma. And we have open globe injury and then closed globe injury. Can someone describe this particular picture to us? Well, so it is what? A hemorrhagic chemosis, which is 360 degrees. And what is the significance of having a 360-degree hemorrhagic chemosis in somebody with trauma? Right, someone mentioned posterior scleral tear. Once you have 360 degrees hemorrhagic chemosis in someone with ocular trauma, there should be strong suspicion for globe rupture. And so this is a patient where you have to do exploration of the eye under general anesthesia. So what is the definition for globe rupture based on the BETT classification? Can someone provide an answer for that? So globe rupture is a break in the eye wall caused by blunt trauma. And laceration is a full thickness wound in the eye wall caused by sharp objects. Now, what is the difference between penetrating and perforating injury? For penetrating injury, there's a single entry wound, there's no other exit. But for perforating injury, you have an entry and then an exit break. Once there's a penetrating injury, you should suspect presence of intraocular foreign body. Now, I would want someone to also mention some of the features that when you see, you should suspect globe rupture, apart from the 360 degrees hemorrhagic chemosis that we mentioned earlier. Soft eyeball, yes. Low IOP, picked pupil, as is on the slides. No, it should be a deep, abnormally deep anterior chamber, not shallow anterior chamber. All right, then what hasn't been mentioned is when there's marked restriction in ocular motility, and then also severe vitreous hemorrhage is a strong suspicion for a globe rupture. For closed globe injury, we have contusion where there's no, there's a damage, but there's no defect in the eye wall. And then we have lamellar laceration, we have subconjunctival hemorrhage, and the other conditions as mentioned on this slide. Now, imaging is important in the detection of intraocular foreign bodies, particularly where you have medial opacity, as in cataract or vitreous hemorrhage, or even hazy cornea that is precluding visualization of the posterior segment. Who can describe this ultrasound picture as shown on this slide? All right, someone mentioned subretinal hemorrhage, but there are a number of pathologies there. So there's a hemorrhage here, there's a retinal detachment here, but you can see some trail of echoes behind this hyperechoic lesion, which is a metallic foreign body. Same phenomenon has been exhibited in the A scan. So why do we do CT scan? Because it's very important in doing CT scan because some of the lesions do not present a lot of acoustic interfaces for ultrasound to detect. And then sometimes the intraocular foreign body is so small that ultrasound may not be able to detect it. But CT scan gives you more accuracy, precise localization of the foreign body. So we have an intraocular foreign body. So this is the eyeball, an intraocular foreign body lodged in the posterior part of the eye. In the axial scan and the coronal, it is located superiorly. So it is posterior and superior part of the eyeball. There are so many lesions or conditions that can occur with blunt trauma to the eye. And of the posterior segment, we have commercial retina that Kwesi has mentioned already, macular hole, retinal detachment. There can also be choroidal rupture, suprachoroidal hemorrhage, vitreous hemorrhage that has been discussed extensively, chororetinitis sclerotiria, vitreous beads avulsion, optic nerve avulsion. So I think a similar picture of this kind was shown to you earlier by Kwesi. So I'd like to know if you do remember the description of this picture. Can someone describe this picture? Someone has given a diagnosis already. Yes, so you have this opacification in the posterior pole. There are some retinal hemorrhages, and this is due to blunt trauma giving rise to commercial retina. Now, it is the damage from commercial retina usually involves the outer retina and the retinal pigment epithelium. So spectral domain OCT, as shown here, there's hyperreflectivity in the ellipsoid or ISOS junction, signifying the area where there's more damage. So commercial is damage to the outer retinal layers due to shock waves following blunt trauma. And we've already described the retinal whitening that occurs after the injury. We've shown OCT changes also. If it involves the macula, the visual acuity can be diminished as low as 660. Other factors that will lead to poor acuity with macular involvement is pigmentation of the macula, associated choroidal rupture, or macular hole formation following the commercial retina that was mentioned earlier by Kwesi. So who can describe these two pictures? So you have these whitish concentric lesions in this montage fundus photo, and there are some hemorrhages. This is classic of choroidal rupture. Now, the OCT shows some bit of transmission of signal due to damage to the RPE Brooks membrane complex. It arises from compression of the globe along the anteroposterior axis, leading to tears in the Brooks membrane RPE, and then also fibrous layer of the choriocapillaries. One of the key things, especially for those with fovea involvement, is formation of choroidal neovascularization. And so there's a need, although it is rare, there's a need to follow up these patients to be able to detect such complication. So this is a fluorescent angiogram of a patient with choroidal rupture. Apart from the area of the hyperfluorescent due to the defect, there were associated CMVs that were also hyperfluorescent. Now, I'd like someone to describe this spectral domain OCT picture of a patient who had blunt ocular trauma. All right, so someone says full thickness macular hole. Yes, that is true. So it's macular hole from trauma, but the A is the apical diameter of the hole. N is diameter of the hole at its narrowest point. BD is basal dimension. And then C is where you have a cuff of subretinal fluid. Now the hole, there's a concept that was described initially where they said the macular hole forming factor is of prognostic significance in determining your anatomic outcome. But by and large, as mentioned in the earlier presentation, the size of the hole is an important determinant. For example, small holes that is less than 250 micron readily close with surgery compared to very large holes of more than 1,000 micron in size. So blunt trauma cause contusion, necrosis, and vitreous traction that can lead to hole formation. Other injuries like lightning and electrical injuries can also cause hole formation. Some of these holes tend to close spontaneously, but some may need surgery for closure. And so there's a need for one to follow them up. And if you see any enlargement in the hole, you should know that this hole is not likely to close, and therefore the need for surgical intervention. Vitreous hemorrhage has been dealt with extensively, and with trauma, it's important that when you see the patient initially, you should try and see if you can do fundoscopy. There might be some localized hemorrhage that has not spread to the entire vitreous cavity, and that may let you see the entire retina often. But if visualization is poor, then there's a need for imaging. For example, B-scan to see whether there's retinal detachment, retinal tear, etc. If there's no retinal detachment, then observation with serial B-scan is often advocated. So someone mentioned, how long should you observe? There are some that may say, oh, you can observe up to 3 to 6 months, but then long-standing vitreous hemorrhage can lead to various complications, including glaucoma, membrane formation on the retina that can lead to traction and epiretinal membrane forming. So whilst you observe, you need to scan them. If, on the other hand, these patients have retinal detachment or retinal tear you observe, you need to operate promptly. Other situations where you might do prompt surgical treatment is when the patient is monocular or has bilateral dense vitreous hemorrhage. Can someone describe this fundus picture of a patient who had this projectile of high speed velocity into the orbit? And this is a fundus picture showing some damage to the retina. Yes, so I think we've already mentioned this condition earlier, and so quite a number of you have responded appropriately in the chat. So you have shock wave generated by deceleration of a projectile that is passing close to the sclera, and that can lead to disruption of large areas of the choroid and retina, and there's retraction of the choroid and retina, giving rise to this bare sclera, and then you may have surrounding hemorrhages. Now, in the management of open globe injuries, you should know that prognosis is guarded, but the initial presenting visual acuity can give you a lot of prognostic significance. They may develop, or they may be having retinal detachment associated with the open globe injury. They may also have intraocular foreign bodies. Now, if a person comes with open globe injury, for example, corneoscleral laceration, first thing is to suture the cornea. If there's involvement of the sclera, you need to explore to determine the full extent of the scleral involvement, and then you repair. This is usually done under general anesthesia. Peribulbar anesthesia may lead to expulsion of intraocular content, so it's not recommended. Now, if there is dislocation of, let's say, crystalline lens into the vitreous cavity, there's severe vitreous hemorrhage or even retinal damage, then there's a tendency to advocate for immediate vitrectomy, but that also has its problem. And so what is usually done is to repair the corneoscleral laceration, allow for cornea to clear up. For young people, there might be acceleration of posterior vitreous separation, and this will make the surgery for the retinal surgeon much easier. In the presence of intraocular foreign body, we have to know the composition of the intraocular foreign body. If it is glass, if it is plastic, and it is inert, that is not contaminated, probably may not cause further damage if it is lodged in an area that is not obstructing vision. But where there's suspicion of contaminations and therefore likely infection, there's a need for removal of the intraocular foreign body. Endophthalmitis is also an issue in open globe injury, and that is why there's a need for early closure of your cornea and sclera, and then also prophylaxis of intravitreal antibiotics, and then also in the presence of intraocular foreign body, you may add some oral antibiotics. So this is a montage of a picture of somebody who had ocular trauma. What is the abnormality in this picture? Someone mentioned gunshot injury. Well, yes, so there's a foreign body lodged in the retina, associated edema, some bit of pigmentation. So should you remove this foreign body or not? Someone said yes. I'm not sure what the response is. Is it to remove the foreign body or not to remove? And that is why we mentioned composition of the foreign body. Let's say if this is copper, it will incite a lot of inflammation and this eye may end up being tisical. If it is iron, it can lead to siderosis bulbar. And that is why composition is very important. What the changes that occur in siderosis bulbar? All right, somebody has mentioned ERG but has not mentioned the various ERG changes. That there's deposits in the RPE. So there's deposits in all the neuroepithelial layers from the cornea down to the retina pigment epithelium. So they've mentioned, some have mentioned changes in the A and the B wave. That is true. In the late stage, there's diminished signals. That's both the A and the B wave. There's a need for us to prognosticate when patients with globe injury present to us. And one of the key factors that determines prognosis is the presenting visual acuity. There's this trauma score, which is the ocular trauma score that we use in determining the prognosis for vision. Trauma can occur from exposure to sun, from our instruments in theater, and then from laser. And that can lead to some formation of what we describe as outer macular hole. The next chapter deals with laser therapy, cryotherapy, and vitrectomy for posterior segment diseases. Some of you have started doing lasers, others have not, but with the advent of antivascular endothelial growth factor agents, there has been diminishing role of laser in some retinal conditions. But laser photocoagulation still remains the standard of care for proliferative retinopathies, especially proliferative diabetic retinopathy. It can be used in other proliferative retinopathies like sickle cell retinopathies, which is common in our setting. So what laser effect is used in laser photocoagulation? So we are using the thermal effect of laser, and in photodynamic therapy, we are using the photochemical effect of laser. Mechanical effect of laser can also be used. This is a patient who had proliferative diabetic retinopathy, vitreous hemorrhage, and then has had laser. So those round whitish spots are the initial laser reactions in the retina following pan-retinal photocoagulation. So what are the laser settings that we apply when we are doing pan-retinal photocoagulation? And how many spots of laser do we tend to aim at achieving? So someone has mentioned power of 200 milliwatt, duration of 200 milliseconds, and then to aim at a minimum of 1,500 spots in a session. Well, so the laser power that you have to use, actually it depends on the spot size. Laser spot that you want to achieve on the retina also depends on the contact lens that you are using. But generally, we aim at a minimum of what? 1,600 spots when we are doing PRP. But in modern day laser, especially with a Pascal, sometimes we go as high as more than 3,000 laser spots. What should be the ideal spacing for our laser? Now, if you look at this area, it should be just one, the spacing should be just one spot apart, but you see that there's wide separation. So this is probably not the ideal in terms of what you want to achieve. It should be the space between one spot and the other should just be one spot diameter apart. But this one, there's a large separation. But then also you shouldn't have confluence of your laser. For example, here, there are two laser spots that are probably touching or abutting each other. So in terms of the lenses that we use mainly, for example, for slit lamp delivery, we use contact lenses, and we have the negative power plano-concave lens and high power plus lenses. But then in modern day lenses that we use, a lot of it are the high plus power lenses that gives inverted image of the retina. The lenses, especially the plano-concave ones, are the Goldman mirror lens, the Januzzi lens, which we really do not use these lenses these days. But what is popular in our usage are those that cause inversion of the image. For example, the ocular Minster and then the Vogue lenses. Lenses have different magnifications, and so they have effect also on the laser spot size. So, for example, for PRP, the spot size that you are seeing on the retina is usually lower than the actual spot size because of what? For example, 165, the magnification is what, 0.51 times. So we've already talked about the spot size, duration of exposure, and then also energy you titrate to have moderate intensity burns. In terms of the laser delivery systems, we've mentioned the traditional one that is usually single spot, and then the Pascal, which is multi-spot, but they are conventional lasers. We have newer ones like the micropore selective retinal therapy. These are lasers that you can use in the macula, and it is thought that it can be repeated because it doesn't cause photocoagulation. Yes, we do a lot of laser treatment, and we should be aware of complications, especially if we are using excessive laser energy or there's misdirection of the laser light. And that can lead to so many complications from the anterior segment to the posterior segment. Now, in our treatment of ocular tumors, and then also sometimes in treatment of IPCV, we tend to do transpupillary thermotherapy using the infrared laser, which is of a longer wavelength and can penetrate much better. We've already mentioned the use of the photochemical effect of laser in photodynamic therapy, but the use of photodynamic therapy has really declined, but for its use in polyps in patients with IPCV and then some ocular tumors. Now, cryotherapy, as already mentioned earlier, an alternative to laser photocoagulation is the use of cryotherapy, where you apply the cryoprobe on the sclera adjacent to where the lesion is. You press on the foot pedal, and you see this necrosis or opacification occurring in the area of interest, and you move it around until you achieve full cryo application to, let's say, for example, this is a retina break. But first of all, you need to know that cryoprobes tend to be very unreliable, and you should confirm that it is working and cooling properly before you use it. It can also lead to some complication. Now, vitreoretinal surgery for ocular trauma and various posterior segment conditions has actually advanced so dramatically in the last 2 decades due to introduction of modern viewing systems, instrumentations, including the trocar systems, where we've moved from 20 gauge vitrectomy to 27 gauge vitrectomy. We have various visualization aids like trypan blue, green. Then we have the tamponading agents like gases, the oils. But the goal of vitrectomy is basically to remove vitreous opacity, to relieve vitreoretinal traction, to restore the normal anatomic relations of the retina and the retinal pigment epithelium, and to assess the subretinal space. For example, when you want to displace submacular hemorrhage, or you want to inject a vector in patients with inherited retinal diseases. We've already talked about epiretinal membrane in the earlier sessions, and as already mentioned, there has to be reduced visual acuity, which is significant before you attempt at peeling the epiretinal membranes. And then also when they are talking of problems with maintaining binocularity. So this is a case of someone with epiretinal membrane with this taut membrane over the surface. And as someone mentioned, if you do fundoscopy in this patient, what you see is a semblance of what? Macular hole, but it is a pseudo macular hole due to the effect of what? Epiretinal proliferation on the macula. And with peeling, there's restoration of the fovea contour. And for some, there might be improvement in visual acuity, but mostly the benefit patients would observe is the decline in the distortion or metamorphopsia that they tend to have. So counseling is key in such conditions. Now, vitreomacular traction diseases have also been discussed in the earlier presentation, so I wouldn't dwell much on it. For focal ones, apart from vitrectomy, we have pneumatic vitreolysis, and then also the use of what? Ochreplasmin. For full thickness macular hole, classic is to do your vitrectomy, ensure induction of posterior vitreous detachment, and then you stain your ILM and then peel the ILM. That improves the success. For very large holes, there are various newer techniques that are used, especially for failed macular hole surgeries, such as the use of the inverted ILM flap, autologous retinal transplantation. Now, somebody might have this large submacular hemorrhage, and as you can see here, this is dark blood signifying its location further away from the retina compared to this lighter colored blood. So OCT is showing that there's a lot of blood in the subretinal space in addition to pigment epithelial detachment. One way to displace this blood from the macula is to do vitrectomy, inject tissue plasminogen activator, then you do fluid air exchange, inject your gas, and then position them prone, and then it will lead to displacement of the blood. blood is lighter colored and is more subretinal. Around the fovea, you don't seem to appreciate that much because it's further behind. If the hemorrhage under the fovea is from the retinal pigment epithelium, then you will not be able to displace the blood. And so you do not even attempt injecting TPA or doing vitrectomy. In such cases, as is shown in this OCT, where you have this high peak hemorrhagic PED, the treatment is with antivascular endothelial growth factor agents. Now, in terms of complications of anterior segment surgery, one of our dreaded complications that we continue to encounter is postoperative endophthalmitis that occurs following cataract surgery, but you can have it occurring in other anterior segment surgeries like trabeculectomy. So my question is, so if you encounter a patient with acute post-op endophthalmitis, how would you proceed with the treatment? Yeah, so someone said if the visual acuity is hand motion or better, but you should inject. That is, you give intravitreal injection, but you need to find out the causative organism. So what you do is you do vitreous tap and send the vitreous specimen for microscopy and then culture and sensitivity. Then you can give your intravitreal antibiotics, which include vancomycin and ceftazidime ideally. Now, if the visual acuity is worse than hand motion, then it's recommended that you should do some bit of vitrectomy instead of just a vitreous tap. However, the decision to do vitrectomy sometimes is not practical in our setting, and so you may do your vitreous tap, you inject your antibiotics, and see whether there will be improvement. If the eye is doing well post-tap and injection, you might as well continue to treat topically. But if the condition is worsening, then you really need to go in and then what? And do your vitrectomy. One common condition that we tend to encounter is after cataract surgery, there's some bit of cortical matter, and for phacoemulsification, sometimes nucleus fragments. So what do you do? If it is just cortical matter and they are not that much, you can actually treat and it may clear by itself. But for nucleus fragment or when you have large cortical matter, you need to probably clear that through surgery. So in what situations would you want to operate? When it is causing secondary glaucoma, when there's lens-induced uveitis, or when there's presence of large nuclear fragment. Now, during your surgery, it's important to look at the retina periphery to determine whether there's retinal tear or retinal detachment, so that you can actually treat whilst inside the eye before having a retinal detachment at hand post-operative. In the chapter we are dealing with, there's this recommendation on what to do for the anterior segment surgeon and what to do for the posterior segment surgeon. For the posterior segment surgeon, I've already mentioned what should be done. But for the anterior segment surgeon, first, you try, I think essentially you should be able to do, when there's PC rupture, you should do good or thorough anterior vitrectomy. You may retrieve some of the fragments that are readily accessible. You do not have to poke deep into the vitreous cavity to retrieve this segment, because you can cause traction that can lead to retinal tears and retinal detachment. So in such a situation, if you can put an intraocular lens, you can do that, close the wound and refer to the vitreoretinal surgeon. So also for dislocated lenses, the common option is to remove the lens and put in another one. But for example, an only eye patient where phakic lenses can be of help. It is an option. So you observe, you give them phakic lenses, or you can give contact lenses. One of the greatest complications that one can encounter is suprachoroidal hemorrhage. And as you can see, there's blood in the suprachoroidal space, and this is showing drainage of suprachoroidal hemorrhage. Usually, if it occurs in the early stage, you might not be able to drain it, and so you have to wait for liquefaction. That may take about 5 to 7 days, and that can you can gain a lot of information through serial B scan, and then you can go and drain your suprachoroidal hemorrhage.
Dr. Braimah, 2 questions that are on the chat that are similar. First question, how many times can we inject intravitreal antibiotics? And another question is, what should be the maximum frequency for repeating intravitreal antibiotics to avoid drug toxicity?
Yes, so in fact, for injection of intravitreal antibiotics, based on my experience in dealing with endophthalmitis, usually 1 injection is enough. If you do your first injection and then you follow up and the eye is not doing well, maybe you are dealing with a different organism. So probably your antibiotics that you injected, that is vancomycin and ceftazidime, are not working. And so you have to think about fungal infection. And if you have a good microbiology unit, they may be helpful in determining the organism. But yes, so you can repeat your injection after 48 hours. And per my experience, I've not had a situation where I have to give more than an intravitreal injection more than 2 times. And so it's not good to do frequent injections. If your first injection is targeting the agent, that should be enough. I'm not sure if I've answered the 2 questions.
Thank you, Dr. Braimah. And a follow-up question, what is the role of steroid in endophthalmitis management?
Yes, in fact, I tend to use, that is for me, I tend to use intravitreal dexamethasone at the first time that I'm giving vancomycin and ceftazidime, because it helps in controlling inflammation and may play a role in hastening recovery, because we do know that most of the causes of acute endophthalmitis are bacterial, they are not fungal. So the question is, if it is fungal, you probably may not be doing good to such an eye. But dexamethasone doesn't stay in the eye for long anyway. It has a short half-life in the vitreous cavity. So I am actually one of the advocates for adding dexamethasone to our injections for patients with acute post-op endophthalmitis. So another problem we tend to face, which is very rare, and for my entire practice, I've only seen 2, and it happens that we have these allied health staff that are trained to give peribulbar injection, and probably they might have issues in understanding the ocular anatomy, and so ending up with penetration of the globe. It's very rare, but when it happens, then you need to see whether there's a retinal detachment or not. Some may come with vitreous hemorrhage, and in the 2 patients I have seen, they came with vitreous hemorrhage and there was no retinal detachment. If there's no retinal detachment and you can see the area and it's small and you can laser, you should go ahead and do laser. But if there's vitreous hemorrhage or there's retinal detachment, then you have to do vitrectomy for such cases. Now, in terms of the various options for treatment of rhegmatogenous retinal detachment, the first thing I would want one person to probably help us, what are the principles of retinal detachment surgery? can anyone offer as the principles for retinal detachment surgery? It doesn't matter the type of surgery, whether it's vitrectomy, whether it's sclerobuccal surgery, or pneumatic retinopexy. So yes, find a break. So you have to find all the breaks, not the break, but you need to find all the breaks. You should seal the break, yes. You have to relieve vitreoretinal traction. One of the various modalities for treatment of rheumatoid retinal detachment, apart from vitrectomy and then sclerobuccal surgery, is pneumatic retinopexy. And if you inject air or gas into the eye and they maintain proper positioning, the fluid tends to clear in about 6 to 8 hours. And then you can do cryo or laser to seal the cause of the retinal detachment. Then we have our traditional sclerobuccal surgery, that you place an explant to cause indentation and relieve vitreoretinal traction. So there are some who advocate for minimal sclerobuccal surgery where you do not drain, but that depends on surgeon preference. Then we have our vitrectomy that I've already discussed earlier, and also is without complications. So there are a whole lot of complications with vitrectomy, and that can be due to intraocular surgery. It can be due to the silicone oil that we inject. Diabetic vitrectomy has already been mentioned earlier, and the main techniques are truncation, where you cut your posterior vitreous cortex, you split your membranes through segmentation and remove them through delamination. Now, with respect to intravitreal injections, they are the common procedures that we do. And this is a patient with choroidal neovascularization with already formation of some bit of subretinal fibrosis. There's retinal hemorrhage, and this patient had intravitreal injection. The end result is the formation of this subretinal scar. The other eye also had similar condition that was detected early, and with injections, it virtually ended with no fibrosis or scar in the macula. So this is the last chapter, and I mentioned earlier that we may not go into it, but gene therapy is an emerging area in ophthalmology, and the retina is a suitable site for gene therapy because it is an immune privileged site. And so there's low risk of systemic dissemination when you inject things there. And then also you just need small amount of vector to achieve your therapeutic response in patients with retinal conditions. And it's being used in the treatment of a number of inherited retinal diseases. For example, Leber's congenital amaurosis, some forms of retinitis pigmentosa, then also X-linked juvenile retinoschisis. Pardon me for the logo in the middle of the slide. I hope you do not appreciate that. Then gene therapy too has been used, is being used, but on investigational basis for certain types of neovascular AMD, where a vector is injected under the retina that will express angiogenic proteins that block the VEGF pathway. The therapies can be RNA or DNA based, but mostly they are DNA based therapy. And this includes gene augmentation, optogenetics, and genome editing. Thank you very much for listening. Enjoy this session between myself and then Kwesi, and hopefully we shall meet you again in 2 weeks' time, where we have review of the chapters and then some questions.